Good afternoon, all. I want to welcome you to today's session of Cancer, the Science of Prevention and Survival. Just want to remind you, we have 2 more upcoming sessions. Next month will be Cancer Survivorship, Diet, and Lifestyle. Next slide, please. As I mentioned, we've had some technical difficulties today. There we go. So here is our team. I'm Julie England. I'm a retired extension agent from Seminole County, Florida. On our team is also Wendy Lynch, who has had technical difficulties today and will not be on. Dr. Wendy Dahl is our team leader, and also our Carlin Raffi, who is from Virginia Tech, and Julie Garden Robinson from Frozen, North Dakota. Next slide, please. All right, just a little bit of information. Certificate of attendance is available at the end of the Qualtrics session. Sessions are being recorded and you'll get the link probably tomorrow. Also, our notes today are not available, but they will be on our landing page and we will put the link in the chat box. And say, and do please complete the short evaluation. And if you like this, tell your coworker. And just want to remind you that the information that we provide is for educational purposes only, and any reference that may be made to a commercial product does not constitute an endorsement from our team members or institutions. Yeah. So our first speaker today is Megan Wessel, who will introduce herself, but she's the Vice President of Regional Cancer Control with the American Cancer Society in the Southeast region. So welcome, Megan.
Well, it's very nice to be with you today. Again, I'm Megan Wessel. I have been with the American Cancer Society for about 20 years, and I have national responsibilities, but I also cover a region from Virginia south to Florida, and I have a team of staff that works with health systems like federally qualified health systems, hospitals, health plans, etc. And they do quality improvement initiatives and evidence-based interventions. We also have a lot of partnerships with our state departments of health and other public health and medical associations. So it's wonderful to be with you here today. Oh, there we go. Okay. I'm briefly, because this is a lot to cover in a short amount of time, but I'm briefly going to go over some information about screening and barriers, a little bit discuss the burden of cancer to a certain degree, also talk about screening guidelines, and then give you some helpful messaging that might be good for you when you're working with your constituents and other partners. Okay, let's talk about the cancer burden. This year in 2022, we are expecting over 600,000 deaths from cancer and about 1.9 million new cases. So these are just some numbers of estimates for 2022, and you can see that they are on the one side, it's new cases, and the other is deaths, and they are combined for both sexes. So I won't go through all of these with you, but sometimes people are surprised when they see the order of these when both sexes are combined. Just give you a minute to look at those, and then we'll go on to just want to acknowledge that over the last 28 years, we have seen a significant decline in death rates for cancer, about a 32% drop. So the progress is real, and that's wonderful. But the cancer disparities and health inequities are real as well. And they're also very unacceptable. So you can't talk about cancer screening without talking about health equity. This is just one example of many that Black females have a 41% higher breast cancer death rate than white females, non-Hispanic white females, even though they have slightly lower incidence rates. Also, when we look at our lower income cancer patients, those that live in our non-Medicaid expansion states, they have 3.5 times more likely to be uninsured and much less likely to receive early stage diagnosis for lung, breast, and colorectal cancer connected to cancer screening. We also know that those are uninsured women, 40 to 64, which is a critical age range for screening, are half as likely to have had a mammogram in the past 2 years if they are uninsured. Also, it's very unacceptable that our Black and African American communities have the highest death rate and lowest survival rate of any racial or ethnic group for most cancers. So why is cancer screening important? Screening not only detects changes before cancer develops, so it's preventative, but it also can detect it early in its most treatable states. So why aren't people doing it? Well, these are some of the top barriers to cancer screenings, and these shouldn't be any surprise. They've been pretty consistent over the years. Unfortunately, we'd like to see these moving in the opposite direction than we're seeing them, but we're still working on that. One thing you'll notice that's new to the list is the COVID-19 and the impact COVID-19 has had on cancer screenings and barriers to it. There is no denying it that COVID-19 highlighted and intensified existing health inequities, including those within the cancer screening space. So this is kind of a complicated diagram, but the bottom line, it shows that because of COVID, there was reduced access to healthcare. And early on, that was exactly what we needed to do to protect our healthcare providers and our constituents. But that reduced healthcare created delays in routine care, such as cancer screenings and follow-up to cancer screenings. As a result, we're seeing later stage diagnosis and also a delay in treatment or modified treatment because of reduced access to healthcare. And all of this together, we are anticipating from multiple studies that have been done that we are going to be seeing an increased mortality in the cancer space due to COVID. And a big part of that is around cancer screening. So some of you might have heard about some research that was done right when COVID hit, right in the spring of 2020, where we really shut things down. And there were about 3 months where we were shutting access to screenings for good reason at that time. But as a result, there were 22 million cancer screening tests that were missed over that 3-month period. That is significant. That's a lot to make up. And this is another view of an impact of COVID-19. This isn't just the 3 months, this is throughout 2020. And if you look at what I circled there around colonoscopies, pink is not good. Pink is a decrease in colonoscopies. So you can see that every state in the country saw a decrease in colonoscopies in 2020, and some decreases were fairly significant. This was a study that we recently published in one of our journals just a couple months ago. So we know that some of the screenings have come back. We know that people are open, they're conducting screenings, and a lot of our health are full, they're at capacity. But what we're seeing is not everyone is getting their screening rates up with all populations. And so it's very important that if we are going to have cancer health equity, that everyone has a fair and just opportunity to prevent, find, treat, and survive cancer. And the prevent and find is critical when we're talking about cancer screening. So let's talk about breast cancer screening. First of all, as many of you probably know, it's the most common cancer for US women, second leading cause of cancer deaths. We have seen a significant and steady decline over the last 30 years regarding deaths from breast cancer. That's wonderful. What's not so great is what I mentioned earlier, is that mortality in Black women relative to white women is really unacceptable. It's 41% higher. So let's talk about risk factors for breast cancer. There are several. One is genetic risk factors, and about 5 to 10% of breast cancers are thought to be hereditary. It's very important that everyone talks to their doctors about whether or not they should have genetic testing done to see what kind of genetic risk they're at. Also, having denser breast tissue increases your risk for breast cancer. Everyone should know the density of their breast tissue. When you have a mammogram in your report, that should be mentioned, especially if you have higher density. You should know your personal history of breast cancer. If you don't know it, talk to your family. If you have family members that are no longer alive, talk to friends of family members. And then, of course, obesity, physical inactivity, and poor nutrition are also will increase your risk for breast cancer. So here are our guidelines. We recommend that for women at average risk for breast cancer, and we are right now revising our guidelines for increased risk, but this is for average risk. But all women starting at age 40 should have a conversation with their doctor about their family history, their breast health history, etc. And if they would like to start screening at age 40 with a mammogram every year, they should have that ability to do so. But no matter what, all women should start at age 45 to 54, have annual mammograms. And then starting at age 55, you can continue to have annual mammograms, or you can shift to every other year. Okay, let's talk about cervical cancer. Over the past 40 years, cervical cancer deaths have declined by more than 50%. That is significant. And the main reason really is the use of screening tests. But we still have over 4,000 cancer deaths and a lot of cases in this country. And of special concern is that non-Hispanic Black women have the highest cervical cancer mortality rate, and the second highest mortality rate is with Hispanic women. So this is still an issue in our country, and particularly a health equity issue. So here are our guidelines. Starting at age 25, all women should be screened for cervical cancer. You can either have a primary HPV test every 5 years, or a co-test, which is both HPV and PAP every 5 years, or a PAP every 3 years. And continue that through age 65. And then at age 65, most people can discontinue screening. So we cannot talk about cervical cancer without talking about HPV vaccination. So the cause of cervical cancer, almost all of them are caused by the human papillomavirus, the HPV virus. There are a couple different types. Actually, there are many different types of HPV. There are low risk one, which cause warts in the genitals, anus, mouth, or throat. And then there are high risk ones that are linked to cancer. HPV is transmitted from skin to skin contact. And most people don't realize it, but the high risk HPV, which is linked to cancer, often does not have symptoms. So what can we do to prevent that? We can make sure that all of our children are getting HPV vaccination. It is cancer prevention. Not only does it help prevent cervical cancer, but it helps prevent other types of cancer like head and neck, vaginal, penile, anal. So it's very, very important, and it is cancer prevention. So here are our recommendations. All boys and girls should get 2 doses starting at the age of 9, between 9 and 12. And then if you have not been vaccinated up until age 26, you should still do so. But it's most effective when you are younger and you have not been exposed to the virus. After age 26, we don't really recommend the vaccination because most people have been exposed to it by then, and it's just not as effective. So let's talk about lung cancer screening. Most of us know that the #1 risk factor is cigarette smoking. It causes approximately 80% of the lung cancer deaths in the United States. But there are other risk factors, including secondhand smoke, radon, asbestos, other exposure to other carcinogens, and then a family or personal history. So you can't assume that just because you never smoked that you might not be at risk. So it's always important to pay attention, especially to your family or personal history. Okay, what are the reasons to get lung cancer screening? This hasn't been around as long as some of our other screenings. It's very important because it's the second most common cancer, and it's the #1 leading cause of cancer death when you combine men and women. When it's found early, before it has spread, it's much more likely to be successfully treated. And often people don't realize, but symptoms of lung cancer do not appear typically until the disease has already advanced. So you can't wait for symptoms, you need to be screened proactively. But even when symptoms do occur, they can be mistaken for other effects of lung conditions, maybe an infection or long-term effects from smoking. So it is really critical that you get screened. And of course, we know that people who have smoked or currently smoke are at a higher risk for getting lung cancer. So guidelines. The American Cancer Society guidelines are currently being revised. So what we are doing is recommending the United States the United States Preventive Services Task Force, that's a mouthful, full around lung cancer screening guidelines. So the way that it works is that you should have annual screening for lung cancer with low dose CT scan between the ages of 50 and 80 if you have a 20-pack year smoking history and currently smoke or have quit within the last 15 years. It's not necessary to continue screening if you haven't smoked for 15 years or you develop other health problems that would substantially limit life expectancy. A lot of people don't know, how do I figure out the 20-year pack? This is a great site called screenyourlungs.org, and you'll see there on the right, take the quiz. If you click on that, there is actually a little assessment to determine how many packs, what your smoking history is relative to the number of packs you've had. So it'll help you determine if you qualify for lung cancer screening. Okay, let's shift to prostate cancer. Starting at age 45, men, all African-American men, should start talking to their doctor about the risks and benefits of prostate cancer screening. And then there are also men, in addition to our African-American community, that are at higher risk for prostate cancer because of a family history. But men who have more than one close relative who has had prostate cancer before 65 are at even a higher risk, so they should start talking to their doctor at age 40. So what are the tests? There's the PSA test, which is a blood test that looks for the prostate specific antigen in your blood. Everyone is different, so don't assume that just because yours is lower that you're free of cancer, or that it's higher that you have cancer. So that's why you really need to do this in consultation with your provider. And then there's the digital rectal exam, which can be done with a PSA or not. The provider inserts a glove, lubricated finger into the rectum to kind of feel around for bumps or hard areas on the prostate and determine if you need to move forward for additional testing. Again, it can be done with the PSA or the PSA can be done alone. Okay, colorectal cancer screening. We have a wonderful guest to talk more about colorectal cancer. So I'm just going to touch on this briefly, but the bottom line is everyone should begin screening at age 45. There are multiple tests, and you need to talk to your doctor about which test is best for you. I don't have a lot of time to go through them, but they are on the side, and our next guest might touch on it a little bit. If not, we have resources that we can provide for you. But this is very important. For a long time, we were at 50, and our next speaker is going to talk about why that was shifted down to 45. And then from the 76 to 85, talk to your doctor about whether or not you should get screened. There are multiple things to take into consideration. And then typically over age 85, it is no longer needed. But the most important thing is to have a test between 45 and 75 on a regular basis. Depending on which test you have will depend on the intervals of the timing. Okay, So key messages to address barriers to screening. I thought you might like seeing some of this. We did some research recently, especially when COVID hit and we saw such a significant decline in cancer screenings. We have made a significant commitment to try to get those screening rates back up. So this is just some data that we collected, that these are messages that resonated with those that are unscreened as far as addressing their barriers to getting screened. I circled one of them because I'm not going to go through all of these, but you'll see that many people face barriers to getting the care they need, but cancer doesn't wait, neither should you. So these are others that you might want to use in your communication. This is one that is addressing barriers related to fear. And all of these highlight that, but the one that I circled there is fear around cancer screening is normal. This is not a blame and shame game that, why people haven't been screened. We never want them to feel like they've done something wrong. It's really more about learning about what it is that can be done to help them. Okay. And then insurance, again, is another significant barrier to cancer screening. And these are some of the messages that we have found resonate with those unscreened. I circled one as an example. Many states have free or low-cost programs to help ensure that everyone has access to screening, even people who don't have insurance or a primary doctor. Because some people might feel, well, I don't have insurance or I don't have a primary care, so what's the point? But there are options out there. So I know we're going to have future topics on a diet, and I can't remember, but I think it was diet and nutrition, something like that. But it's really hard to talk about cancer prevention without at least touching on this a little bit. So I wanted to point out that currently the American Cancer Society is projecting that 42% of new cancer cases are potentially avoidable. And that includes 19% of cancers that are caused by smoking, and 18% that are caused by either excess weight, drinking alcohol, poor nutrition, and physical activity. In fact, 11% of cancers for women are associated with excess body weight. And so that's one thing I wanted to kind of point out right now, is that being overweight or obese increases your risk for several cancers. Not all of these cancers have routine cancer screening for average risk individuals. And so it's very important to do everything that we can to prevent them. And being overweight or obese increases our risk for quite a few. So what can you do? And I know you're going to learn more about this at a later date, but very briefly, please achieve and maintain a healthy weight throughout life, be physically active, follow healthy eating patterns at all ages, and it's best not to drink alcohol. I know many of us do, but we need to try to limit it to 1 a day for women and 2 for men if you drink at all. Okay, so key takeaways. These are the guidelines, and I'm not going to go through all of these, but this is another way to look at it by age category. So you see 25 through 39 is just cervical, 40 through 49, depending on your gender, it's either breast, cervical, and colorectal for women, or cervical, colorectal, and prostate for men. And then age 50, everyone should be screened for colorectal cancer, lung cancer if applicable, and then women for breast and cervical, and men for prostate. I think I said cervical earlier for men, but I think you probably figured that one out. Okay, so this is 2 more things and then I am done. You are not expected, none of us are expected to be experts in everything, to know all the science, to really understand all the guidelines, but what we can do is make sure that the community understands what are some critical questions to ask their doctor. And I really like these. If you can answer some of these for your constituents, great. But if you can't, you can at least direct them to consult with their practitioner. So I'm not going to read through all of these, but it is important that they ask questions like, how often should I get screening tests? Will my screening be covered by insurance? Where can I go to get screening? You might have the answers to some of these, and if you do, great. If not, direct them to talk to their doctor. And then I think that it's always very helpful to have conversation starters when you're going to talk to somebody who is not compliant with their cancer screenings. And you want to do it in a non-threatening way and a non-judgmental way. And so some of these questions I found to be very helpful. I care about you and your health. Are you getting regular cancer screenings? You can mention that my breast cancer screening is coming up. Have you scheduled yours? There are other things that you can do to help them along. So that's it for me. I hope I did not go over my time. I probably went a little quick, but I'm always cognizant of leaving time for Q&A. So I'm going to stop sharing and pass it over to Melissa.
My name is Melissa Vilaro. I am an assistant professor and extension specialist, health and wellness in the Department of Family, Youth, and Community Sciences at the University of Florida. And I have worked in cancer communication as well as in community level nutrition. And the focus of my slides today will be on specifically colorectal cancer. And so some of the topics Megan just discussed and introduced, and we'll be able to kind of review, recap, and take a little bit more of a deep dive into some of the information related to colorectal cancer specifically and cancer screening. So the learning objectives today for my portion of the talk related to colorectal cancer screening. We hope that by the end of the session, you'll be able to identify the different ways to screen for colorectal cancer, or sometimes they're called screening modalities, and discuss the prevalence of colorectal cancer screening among U.S. adults, and identify kind of the rates that we are currently at and where we would like to be in terms of goals. We'll also look at some of the United States Preventative Services Task Force screening guidelines for colorectal cancer. And as Megan mentioned earlier, we'll talk about some of those updates in terms of screening recommendations. And then at the end, we'll just talk a little bit about some of the ways we know that recommendations from a doctor can impact screening, and then we'll have time for Q&A. So here's just another version of the outline. So this is a slide from the first talk. If you didn't attend the first talk, we really focused on prevention, and this cancer control continuum is a great way to try to understand the different resources and players and information we need to address cancer at different stages. And so screening really falls between prevention and detection. And for colorectal cancer specifically, screening can both be prevention and detection. And so for primary prevention, as it's defined, it's identifying cancer before it begins. And so colorectal cancer screening can identify polyps and precancerous cells. But when it is detecting maybe an early or late stage cancer, when colorectal cancer, or any cancer for that matter, has already begun, screening functions more as secondary prevention or detection. So sometimes you'll hear screening talked about both as a prevention, but also as a detection tool. So I'd love for people to type in the chat, and this will be more of a kind of what you remember, a recap of some of the topics that Megan introduced. So we'll see how well people remembered all of the different guidelines, because she presented all of the cancers. But for colorectal cancer specifically, I just love for people to type in the chat if you know any options that are available or recommended for colorectal cancer screening. Please type those in the chat, what screening modalities that you are familiar with or you've heard of, as well as what age should average risk adults screen for colorectal cancer. So you can type both of those in the chat, both the modalities that you know of, and the age. And if you want to get really fancy, you can put the age range in there, what age range is recommended for screening. And I'll just give people a second to type that in the chat. So I see a lot of colonoscopy, FIT, FOBT. Age is now 45, was 50, 45, 50, 45. So let's see, Cologuard, okay, yes. Home test kits, colonoscopy. Yeah, that's great. So I see a lot of comments, age and modalities. I'll give people a few more seconds to type their answer. I haven't seen anyone put the age range, a couple age ranges, 50 to 75, great. Extra points for typing in a range. Okay, so yeah, that is great. So everyone was really paying attention. So I had this in here before I knew Megan was going to present the ages, but I think it's great because the guidelines have changed, and sometimes it can be difficult to remember all the different ages and recommendations. So but you guys did great. So in terms of screening modalities, there are various ways that you can screen for colorectal cancer. And as I mentioned, the screening test for colorectal cancer can help find polyps or cancer that's already begun. So polyps or precancerous cells. And those tests look for signs of cancer in either the stool, so a lot of people did mention stool tests, or in the rectum or colon. And so you can see an image here that is essentially showing the different areas that of the colon, the upper, lower colon, as well as the rectum. And so a stool test, there are a couple different types. I saw that people chatted about the FOBT stool test as well as the FIT tests. Those are recommended to be done once a year. And how it works is it is essentially a test kit that can be used at home. I think occasionally they could be used in clinics or certain types of interventions that I know of that have used them at the clinic, but I think traditionally they're used at home. And you're given a kit that is sent to you in the mail. You use a stick to brush or sample a small amount of stool, and then you return it to the doctor. A lot of times you can put it in the mail and send it to your physician or the lab, and you can receive the results. Stool tests can be used alone or in conjunction with another type of screening test. So occasionally, if there is follow-up required, so you might be asked to have a follow-up colonoscopy, but those stool tests can be used alone or in conjunction with other screening types. And then I saw a lot of people mentioning the colonoscopy. And so the sigmoidoscopy is another type of test that is done. Sigmoidoscopy every 5 years, it's done at the clinic with a short, thin, flexible tube, which checks for polyps or cancer in the rectum and the lower colon. And then a colonoscopy is done every 10 years. And this is a longer, thin, flexible tube that also checks for polyps or cancer in the rectum and the entire colon. And so these are the kind of traditional recommended screening tests. You can see that they vary in terms of how often they're recommended and kind of where you can do them, either at home or in the clinic. And so there is a big push in a lot of research to try to understand how to get people screened. And some of the literature indicates that giving people a choice of modality can help increase screening rates, as well as, which was mentioned earlier, a recommendation from a doctor to screen. So those are really important components of trying to increase screening rates among different communities and populations. So I know this slide looks a little bit busy, but many of you in the chat also were talking about or mentioned the age. Some people said 50, but most said 45. And so it is kind of good to remember that some of these guidelines can change and be updated. And so previously, I think it was 2021, the guideline was officially updated to 45 years. And so for average risk adults, the recommendation is to start screening at 45. So if you're high risk, there are different slightly different guidelines. However, if you go to the USPSTF, United States Preventative Services Task Force website, you can actually find a lot of information about the recommendation, how they were made, literature about different levels of risk. So it's a great resource to look at in terms of to really understand the guidelines, and you can see the history of the guidelines and when they were changed. And then I put some references down at the bottom for papers that really looked at over large data sets to try to understand kind of risk and benefit of screening, and some of the information that informed the change from age 50 to 45 was recognizing that about 10% of new colorectal cancers were occurring in persons younger than 50 years. And so that some of the evidence that was pooled to look at really what is the benefit of changing the guidelines comes from this Swati et al. Study. And you can see that one of the things they looked at was if we changed the screening age to 45 compared to 50, one of the outcomes was how much additional life years are gained if you start screening at age 45. And so looking at these large data sets, they looked at this overall, but also based on different types of screening modalities. And they found that, there were benefits for reducing mortality or additional life years gained if you started screening earlier. And this was, these are estimates. There's additional figures in this paper that I have posted here, where if you want it, they look at, deaths averted, incidents prevented, so new cases that are prevented. And so all of this data kind of was looked at over a number of years to inform the update to age. So now the age is 45 for colorectal cancer screening. I'm gonna, slides are frozen. There we go. Okay, so I have another question. So just take a guess and type in the chat. Given that colorectal cancer is also a very preventable and treatable disease if caught early, so screening is really important tool for prevention and detection. Take a guess, what do you think is the goal for screening rate? So another way of thinking about this question is what % of adults use screening tests, or what is the goal for what percentage of the adult population should be getting screened, given that we know we're not at 100%, right? We want to get rates. So what do you think is the target goal? What % of adults are we trying to get to? Obviously it's 100, but in terms of national standards, what are we kind of working towards? And take a guess. This is kind of, there's not a right answer. I'm just kind of curious, and you can type in if you want to say, what is the current, what is the goal? Feel free to type that in the chat. This is just to get a sense of where we're thinking we are with screening. So I see some 50, some 90. Our goal is 90, our goal is 65, 65, 80. Say some current 55, current 38, goal 75. Okay, great. I'll just wait for a few more responses and then we can talk about screening goals. Okay, so I see a bit of a range from about maybe goals being between 50, 90, and some current suggestions. Yeah, and these are all really good guesses. And there's not necessarily one answer because obviously it can vary by state in terms of what the current screening rates are. But if we look at an overview of some organizations' targets for how for screening for colorectal cancer specifically, we can see that the National Colorectal Cancer Roundtable, they've had a goal to get 80% of adults screened in every community. And I really like the way they frame their goal because they talk about, obviously we can have a national goal. So if you look at the nation, how many adults in the United States in general are getting screening. But as we can see on this map here, screening can vary based on a lot of different things, your region, where you even live. So you can see the darker colors indicate lower screening rates. And so you can see some differences even just in screening rates in different states. And so thinking about getting 80% of adults screened in every community really does incorporate a health equity perspective that Megan had mentioned earlier, and that it's not enough really to think about an overall target, but it is really important to think about areas or communities that might be experiencing screening disparities. And that is really, I think, a goal for many initiatives and organizations that are trying to increase screening, thinking about how we can meet the needs of communities and populations that might be having different barriers to screening, and thinking about really how to lift everyone up to increase access and use of screening. And then Healthy People 2030 is a organization that you might have heard of before. They look at a lot of different metrics for various health conditions, not just cancer, and they set goals for population health. And for colorectal cancer screening, they've set a target goal for 74.4% by 2030. And they base their targets based on kind of baseline level data. So they'll look at where the state of screening is and kind of project out. And so you can see they have a little bit more of a modest goal, but essentially you'll see that, the targets are between 75-80%. And based on the map here, this is 2018 data before the screening rate was 50. So when you look back over data, it's good to pay attention to if it's before or after the guidelines have changed, but you can see that some states are around 70, 72, some states are a little bit lower in the 60s. And so there's certainly work to be done to get to our target goals. Another way to think about, we just looked at a map by state, and I wanted to present some resources for folks who might be interested in taking a little bit of a deeper dive into looking at screening by different metrics. And so the NCI, or the National Cancer Institute, has a state cancer profiles page where you can actually use an interactive map. And if you want to look at one particular state, you can do that. Or even county or different types of metrics, screening, mortality, incidence. You can kind of look at these different statistics and interactively look for different types of data. The CDC has a similar resource, which is their state profile resource. And essentially, I think these are great. I love an interactive map, and it allows you to look at data in a lot of different ways. You can even export them to tables. And so if you're looking at, for information maybe about your county or your state, these can be really useful to help you understand where there might be some disparities or the current state of screening in your area. And so, as we also mentioned, there are some racial disparities when it comes to most cancers, and colorectal cancer screening is not saved from that. So this is a paper that looks at Black and white differences in colorectal cancer screening and screening outcomes. And essentially, this is a great paper I've linked to if you're just interested in kind of a narrative review of what might be driving some of these disparities. It's just kind of a very contextualized description and review of the literature that's out there. And so I would encourage you to look at it. But essentially, what we know based on the numbers that there's higher rates of colorectal cancer incidence or new cases among Black adults. This paper describes, they've looked at a number of studies, that a lot of this is driven by lower rates of screening. And in a lot of cases, this is due to differential access to screening. So it could be because of insurance or other types of structural barriers, but it's really important, I think, to think of, again, from a health equity perspective, how do we address some of the barriers related to why there might be racial disparities in screening? Because ultimately, when you think about the cancer care continuum, and certainly, as we've talked about COVID affecting as kind of one of the new barriers affecting screening rates, it's really important to kind of try to understand and address some of these barriers to screening. And so, again, I've just put an example of the map so you can see the differences by race. I just kind of went to the interactive map and looked at screening by race. So you can see for Black adults versus white adults, and you can kind of see that the map changes and looks a little bit different. And so, by the numbers or kind of a narrative review of what are kind of some of the underlying issues, you can kind of start to get a picture of what the disparities are and what might be causing them. And so the last thing I kind of wanted to briefly touch on is that there are lots of evidence-based resources out there to try to improve or increase screening rates for colorectal cancer. In this short amount of time, there's not really a lot of time to look at all of the resources that are there, but Megan had mentioned this in her talk, and I think it is a really important point that the role of a physician recommendation is really important for screening. And this was just an example of a review that looked at how effective an intervention was, and this related to assessing a provider interaction and then giving the provider feedback for how their recommendations were. Basically their recommendations with patients. And what they found that was when they had these interventions that were related to provider assessment and feedback, they found an increase in screening. And so not just for colorectal cancer, they looked at breast, cervical, and colorectal cancer. So they found a median increase of 13 percentage points. And then for colorectal cancer specifically, they found that when that intervention related to physician recommendations and feedback to the physicians was implemented, colorectal cancer screening using the Fecal Occult blood test or the Stool test, it increased by anywhere from 12 to 23 percentage points. Interesting about this review, they did find that the recommendation was stronger or it increased when it was the stool test. They did not find that same effect for the sigmoidoscopy or other screening methods. So it's kind of interesting to think that the recommendation also might be linked to modality. But in general, if you're interested in kind of this type of information and how recommendations and screening might be affected by recommendations, I've linked to some studies here that kind of talk about it in context. But certainly there are, the role of a physician recommendation and then how we think about that and maybe implement that in a broader context. Research looking at things like community health workers and a recommendation coming through the electronic health record, or some of my research that we're using virtual health assistants. The physician recommendation is established literature, but there's certainly kind of new avenues opening up to how do we expand a recommendation, and does it always work for as a healthcare worker recommendation the same as a physician recommendation, and does it only work for the stool test, or will it work for other types of screening? So these are interesting kind of research questions, but certainly are important for thinking about how do you apply and talk to people. Just as Megan presented the messages, how do we create messages that are effective? So I think that is my last slide. it is. So just thank you for your time, and I will stop sharing for questions.
Hello from Fargo, North Dakota, where it is very cold. I had a question early on, and I believe this is for Megan. What causes denser breast tissue?
Sure, yeah. So first of all, dense breast tissue is very, very common, and you can't feel it on a mammogram. I mean, I can't feel it through a breast self-exam. You have to have a mammogram. It is related, it can be hereditary. It can be related to hormones. Some medications like tamoxifens can impact your density, age, whether you've had children, things like that. And I did write down some of the questions if you want me to whip through them really quick that were asked. I'm happy to do that. Okay, the vaping. I'm happy to give some information about vaping because there was a question related to that. I'll make sure that your contacts get it. I want to clarify the question about colonoscopies. What Melissa covered was screening for average risk individuals. If a polyp is found, there are different intervals for follow-up colonoscopies. So that varies. Somebody is having, if you have dense breast tissue, you always have dense breast tissue. It fluctuates, actually. Your density can fluctuate throughout your life. As far as somebody asked a really good question, it was not a dumb question, about if you're trying to find your family history and somebody says, well, somebody had cancer, but they don't know what kind they had. If you can find out at least the age that they had it or they died, and then just talk to your physician and let them know, listen, I want you to be aware that I had a first-degree relative that had cancer that died maybe young. If they're talking about their 70s, 80s, 90s, it might not be as impactful, but we're talking about younger. At least knowing that would be helpful. And then there was a question, a wonderful comment about Black women at higher risk for at higher mortality rates, also getting cancer younger with triple negative. Absolutely right. And a couple things that are happening. Again, we're revising our guidelines for high-risk individuals, so that could play a role. The other thing is we're investing millions of dollars to get a better understanding of why that's happening. We know some factors, but we don't know it all. There was a really interesting study that was done in Virginia that looked at eliminating racial bias within the healthcare system, and it was able to eliminate the mortality disparity with African-American women and white women, addressing racial bias. So that's an option that we need to explore more. And then I just wanted to mention briefly, we are establishing a roundtable. We established the colorectal one many years ago. We have a lung cancer, an HPV, and a survivorship, and we are creating a breast cancer, and we will be looking at that issue that you brought up. Thank you for bringing that up. Hope I did that quickly.
That was great. Thank you. I have a question for you too. If we look at the role of genetics and cancer development, where are the closest linkages with genetics? So if I had a mother or aunt or grandma who had a certain type of cancer, which would be most concerning in terms of types of cancer?
Well, it varies. First degree relative is always most relevant, and multiple first degree relatives, depending, it's really all over the board by types of cancer. So you would really, if you have a concern about it, you really should talk to a provider to see if you should see a genetic counselor, because genetics are very complicated, and there's all sorts of implications about what your risk is and what steps you do or do not want to take. So it's best to talk to a genetic counselor if you have concerns in this space. The majority of us probably don't, but there are some that do, and in that case, you need to talk to a professional about it.
Nicole followed up. Sorry for my voice here, I have a cold. Can you provide the link to the VA study eliminating racial bias?
Yes, and it wasn't, it was actually in North Carolina, I believe, but I will get it to you. And then I did reference a study of the VA hospital systems earlier around colonoscopies, and I can share that. That was in the, I think the British Journal of Medicine, I think, but I can share that. And I think I got the other question.
Well, the other host, do you see any questions that haven't been answered?
I whipped through that because I knew we were kind of running late on time. So I hope that was okay.
Oh, that's great. Thank you. Any other questions? We have 2 minutes left.
We
I
are doing,
actually have a question for you, Megan. So are there any recommendations for genetic testing and genetic counseling? So I know there's recommendations for screening, but I'm kind of curious about this idea of are genetic counseling appointments recommended, or is it more of a context-based?
it really is looking at your particular situation to determine, there are some cancers that you get genetic testing after diagnosis. There are some that you get that are helpful to get before diagnosis. Preventatively, like with breast cancer, if you have a history of breast or ovarian cancer in your family, you absolutely should talk about some genetic testing. That is really critical. Ashkenazi Jewish women should all explore genetic testing for breast cancer. Black women should look into that as well. So it's very dependent on your situation. We have some good information on our website that I can share. But I'll tell you that I have ovarian cancer in my family. My mother, my grandmother, and my aunt all died of ovarian cancer. And I tested negative for BRCA, which was good. But I was quickly told there's probably other genetic variables that we can't test for yet that put me at higher risk. So if you have contact with a genetic counselor, those are the kind of conversations that you can have. There's only so much we know now. We don't have genetic testing for everything yet.
Final question from Gianna. What is considered a first-degree relative?
That's a mother, a father, or a brother, sister, or child. What do you suggest for adopted patients that have no family history? Well, if it's somebody that is post-diagnosis, so they've been diagnosed, depending on their cancer and their situation, they might want to get it if they have biological children, so they can better prepare their children. So if you don't have, if it's for preventatively, that might not be as helpful because you don't have that family history. But if you want to do it to either determine what the best treatment is for you or to better prepare your children, then I would recommend talking to a genetic counselor.
Well, I think we'll wrap it up. Julie, do you have any final comments?
There, now I'm unmuted. Out of practice. So no, we want to thank both of our speakers, Melissa and Megan, and of course the other Julie for minding the chat box and our other team members. So we will see you next month for discussion on diet and cancer. Thank you all.
Thank you.
Thanks, everyone.
Thank you.